is taking Pradaxa, do they have to come off of that for what length of time before the total hip replacement?
Usually about 10 days.
10 days. And does that increase the chance of blood clot, DVTs?
I don't think it increases your chance of blood clots unless you've had a history of thromboembolism.
AFib?
If you have AFib, probably, but you're probably on an anticoagulant anyway, so we'll probably stop anticoagulant for a couple of days before the surgery and then restart it immediately in the day of surgery.
The Pradaxa is the anticoagulant that he's taking.
He's taking that now?
Uh-huh. And baby aspirin.
Right, but if he's having AFib, we usually, if it's significant AFib, to where he's symptomatic, I'd probably keep him on it. And if it's a total hip, probably going to expect to lose some blood and have a transfusion afterwards. Total knees, it's not as much because we use the tourniquets, but probably keep him on it like until a couple days before the surgery, and then we start it immediately or start coming in right afterwards, because AFib can be a problem.
And pacemaker, does that make any difference?
Not to me, not to me. The anesthesiologist, and that's what I was talking about here with the coordination of our care. When we have a patient, if it's your husband that you're talking
It
about.
is.
If we have a patient like this, come into the office, the hospital experience does not start with the day you walk into the hospital. It starts with the first time you come and see the specialist, or even before then, or when you see your primary care physician. And if everybody's on the same page with how we're going to treat these, if we do our job in educating our primary care physicians and educating our community leaders and have everybody on the same page, so when you go and see your primary care physician and say, well, thinking about having a hip replacement, well, this doctor's going to really know, well, they're doing great work over at X hospital. We want to say Trinity because we're here at Trinity. And I know how they do things over there. I know that the doctors are using this for anticoagulation. They're using it for this amount of time. I know that even though I don't go there, I know the physicians that are working there and how they do that. I know that the anesthesiologists are doing a great job because every month they send me updates about how well they're doing, so I really feel comfortable. So then you have a feeling of, well, these people really know what we're doing. So I don't have a lot of concerns about this. So again, the anesthesiologist, if they're on the same page with us and we all know what we're doing, all of those things are answered prior to you coming to the hospital, which makes it a whole lot easier for you instead of when you come into the hospital and you walk in the door and everybody goes, oh my God, what are we going to do? Because I'll tell you, it's been like that for a long time. And what we're trying to get away from.
And that's so frightening to the patient.
Sure it
and
is,
the family.
and the family, and it increases the anxiety of everybody around them. It increases the anxiety of the professional staff too, the nursing staff, and everybody else. So these are the things that we have to have organized beforehand. So, and that's the great advantage in total joint replacements is we're doing this electively, so we have the time to get all of this organized. And that's what's very helpful.
What are the treatments before, like you would do before you would consider like a total knee replacement?
Well, it really, if you say you come into the office and you've got knee pain that's been there for 5 years, you're 60 years old, and you've been to your primary care physician and he's put you on some arthritis medication, and those haven't really worked, and you've been down to the gym and you've done some exercises. That hasn't really worked. I put on a couple pounds, kind of lose some weight on and off, and that hasn't worked. So now you're coming to see the orthopedic surgeon to see what you can do. Well, again, if I've done my job of educating my primary care physicians that refer patients to me, they're going to know that we have special programs for people with arthritis, for water therapy, for physical therapy. We have special medication recommendations that we use. I generally add glucosamine and chondroitin sulfate to the arthritis regimen because it's been shown to be effective in improving the health of the cartilage inside of your joint. After that, we talk about doing something that's called viscosupplementation, and it's an injection of hyaluronic acids, and that's been shown to decrease arthritis pain over 1 or 2 years. So we're trying to do everything we can to keep you out of the operating room. Now, however, if you have a significant deformity in your joint that is not going to be affected by any of those, that's the point where you have to sit down and say, well, we can try a lot of different things, but I don't think they're going to be effective. And it's a matter of letting patients and letting our primary care physicians understand that we're all on the same page of we want to get people better, we want to get them better the most effective way.
Range of motion for total knee replacement, do you have a 90 to 110 that you normally like? Do you have 125, 130?
80 degrees to sit down in a chair comfortably, 90 degrees to get up from a seat that's below your hip. So after that, then I think you're talking about the patient comfort. But when I talk with my therapists about it, I want to make sure that 90 degrees is really kind of the minimum what I want, and we try and approach that before they leave the hospital. Thanks, guys.
If you brought your parking ticket with you, I'll be glad to stamp it and validate it so you can get out of the parking desk. And we still have some refreshments back here.
That's okay.
This is a good